are you okay if I start admitting
Yeah.
waiting room people? Okay.
I think you can start admitting waiting room people. That's fine. We have about 4 minutes left before we start. Thanks, Emily.
Oops. How do I minimize these boxes on the side so that I can still see the whole slide?
At the top right, you should have something called view. You can do it from there.
Yeah, I tried that, but it changed the slide instead of minimizing it. Okay, now it worked.
That worked? Okay, super. So for everyone on the line, we'll get started in about 2 minutes. Good afternoon, everyone, and welcome to another year of Medical Grand Rounds. Thank you for joining us virtually once again for rounds. And just a quick reminder before we get started that we will ask you to enter questions in the chat at the end of the presentation. I will go through those questions and ask the presenters the questions myself. And I will ask you to please answer a brief survey at the end of Medical Grand Rounds. This will let us know that you were present today and gives you a chance to give us a sense of your appreciation of the rounds today. I'd like to introduce our speakers. We have Dr. Christos Tsoukas and Dr. Vanessa Polito who will be speaking to us today. About to be or not to be, evaluating immune competence in the era of B-cell depleting therapies. Dr. Tsoukas is known to many of you, if not all of you. He's a professor of medicine at McGill University. He's the director of the Clinical Immunology and Allergy Lab at the MUHC. He's a professor of medicine and experimental medicine, senior investigator at the RI, and director of the Clinical Immunology and Allergy at McGill University. He's a fellow of the Royal College of Physicians of Canada, a fellow of the American College of Physicians, and a fellow of the Canadian Academy of Health Sciences. He was a pioneer in HIV treatment and research and the first to demonstrate the risk of acquiring immune deficiency from blood products. In 1984, he established the first Canadian center dedicated to the diagnosis and comprehensive care of adults with both primary and secondary immune deficiency. In recognition of his work, he received multiple awards and was inducted into the Order of Canada in 1999. Currently, his clinical research focuses on the use of diagnostic vaccine challenges in the management of immune deficiency. We also have with us Dr. Vanessa Polito. Welcome, Vanessa. Dr. Polito completed her internal medicine residency at McGill University and is now a second-year fellow in the Division of Clinical Immunology and Allergy. Thank you both. Thank you for opening up our grand rounds here, and I will pass you the microphone. Chris, the mic is yours.
Thank you very much, Dr. Giannetti, and specifically because today, to the date, is the day that everything started 40 years ago in terms of the research on immune deficiency within our division. And also that because with COVID, there's a heightened awareness today of immune competence, immune compromise, deficiency, and so on. So I thought it would be very important for us to just review what's happening in secondary immune deficiencies at the beginning of the year, and what has been going on in our division for many, many years. As you know, we're up at the Montreal General. We don't really spend that much time doing immune deficiency down at the Glen, but we are very active. I have only one disclosure, that I sit on the board for Gilead Sciences to review independent investigator grants. I have no conflict or overlap at this presentation. So I will start off by introducing what is adult immune deficiency and give you a little brief summary of what happened in the 40 years since we established this treatment center. Then I'll go on to talk about knowledge of B-cell biology and specifically about B-cell depletion therapies, and then our approach in evaluating immune competence in patients that we get referred with these problems of secondary immune deficiency. There are certain challenges that are encountered with treatments, and I will let Vanessa Polito talk about these and at the end summarize what we should know about these therapies. So what is immune deficiency? It's the result of a diverse group of abnormalities of the immune system that result primarily, but not solely, in increased incidence of infection and malignancy. The European Society of Immune Deficiency has extended this in terms of the immunopathology to define patients that have these problems, that also include immune dysregulation as part of the picture. Now, today we don't really talk about primary immune deficiency very much. We refer to it as inborn errors of immunity. Why? Because these patients have congenital or hereditary causes for their deficiency. There's more and more cases of secondary immune deficiency that occur, and these are acquired. They're transient or permanent, and they are a result of a variety of diseases, some viral, some autoimmune, chronic diseases of liver and kidney, as well as lymphoproliferative disorders, and also because of environmental factors, and more importantly, medical interventions that include a variety of interventions, but lately the focus has been on biologic therapies. So in terms of what is new in immune deficiency in the last couple of decades, there's an increased understanding of the role of mutations and inborn errors of immunity, and there are now over 450 genes that have been linked to these deficiencies. There have been numerous advances in technology, specifically looking at genetic defects, and the data sets keep on growing every day. There are improved outcomes for treatment with stem cell transplants and gene therapy in primary or inborn errors of immunity. In terms of secondary immune deficiency, we're seeing more and more adults that have problems, and lately more adults that have this on the basis of the use of B-cell depleting therapies. So, as I said, today is the 40th anniversary of our involvement with immune deficiency. The first cases of immune deficiency were described in 1952, then 54 in adults with common variable and good syndrome. And almost 15 years later, patients were being treated with gamma globulin replacement, both at the Vic and the Montreal General. Initial treatments were intramuscular, and then they were switched to intravenous. Lately, the trend has been to treat patients with subcutaneous infusions of gamma globulin. Now, adult immune deficiency was not well known until 1981. The first cases of gay-related immune deficiency arose. And that acronym was switched to AIDS. Almost a year later, we started studying patients that had received blood products in a hope of finding if there was a transmittable agent or a transmittable process by which individuals could acquire this syndrome, which at that time was not known as AIDS because the virus was not isolated and not described yet. What we did find was that 70% of hemophiliacs had severe decreases in cell-mediated immunity. And this created much concern in the blood banking sector. And for the next 7 years, I was very involved in blood product safety and in transfusion safety. At the same time, the Medical Research Council thought it wise to give us a very large grant to set up a screening center, a screening lab, where we monitored patients from across the country in all 10 provinces. And in that process, we developed expertise in a number of immune-based therapies. At that point, there was no MUHC, and it was unusual to see cooperation between the Royal Vic, the General, and the Children's, but we had an excellent program on thymic transplants. In an attempt to improve their outcomes, we would collect thymic tissue that was about to be discarded by the cardiac surgeons operating on young children. And using explants in individual cells, we would infuse them into patients with AIDS in an effort to change their course. Unfortunately, they all died, but we learned quite a bit and started to do more and more immune-based therapies. The lab grew and gained expertise in a whole host of immune testing. And what you see here in this photo is a picture of me in a makeshift lab in an operating room in Chisasibi, northern Quebec, where we flew 2 tons of equipment in our group to study the Cree Indians that were developing leukoencephalopathy, mostly in children, and these children were dying of this disease, and much of the clinical features were similar to that what was being seen in pediatric AIDS. The number of studies increased. We've completed 182 clinical studies, and the cryobanking facilities grew. We had 60,000 samples from a whole host of studies that were not only local and national, but international. And the support for all these investigations and the cryobank came from a number of sources, both private and public. This continued until the year 2014, where HIV was well controlled and managed. And a lot of the clinical work was then shifted down to the Vic from General. And yet we kept the non-HIV immune deficiency care and research at the Montreal General. In 2012, we published on our cohort of patients that had been referred to us. These were mostly women. The ratio was 60-40 female to male. These were individuals that were in their mid-40s and almost exclusively Caucasian. The majority we found had primary immune deficiency, and some had secondary immune deficiency. The overall type of immune deficiency was humoral. As you can see here, we are no different at the MUHC than in other centers in the world where most adults have humoral deficiencies. Now, what was unexpected was that despite the fact that we were able to validate and prove that the patients that referred to us had an immune deficiency. 64% did. Despite the high index of suspicion by referring physicians, immunoglobulins were surprisingly not carried out at the time of referral, and we were the ones doing the first levels on these patients. What was also surprising was we couldn't fit patients into the categories that we knew in terms of what was accepted immune deficiencies. And we found a group of older individuals that actually had normal levels of gamma globulin, but had a history of very severe or recurrent infections. These are individuals between the ages of 60 and 72, and all of them had low levels of B cells. On this graph, what you see is the gamma globulin levels across the spectrum from normal non-immune deficient individuals to those with common variable immune deficiency. And in between, you see individuals that had borderline immunoglobulins, but had 2 standard deviations below the mean of B cells. So it was a perplexing issue. Why would these individuals have recurrent infections despite having normal immunoglobulin levels? Over time, the referral basis changed. This is a decade by decade change that you see here. Most of the patients initially came from the Montreal region, 66%, and yet now 40% account for these for the whole cohort that we see and follow. And what is interesting and pleasing is that our referral basis increased to come from every single administrative sector of Quebec. We also had, for a while, we were seeing a substantial number of patients outside the province. We've evaluated patients all the way from Labrador and Newfoundland to the Yukon. And these patients, unfortunately for them, had to come back for follow-up visits. Now, what also happened to the cohort that we follow over the decades has been not only an increase in the number of patients that you see here on this column, but also a change in the mean age. As you can see earlier on, they were a bit younger than they are now. They're still in their 40s, but a little bit older. And why is that? It's because we're now seeing more and more secondary immune deficiencies in proportion to the primary. The fact that we're seeing less in proportionally of the humoral immune deficiencies that are considered primary is partly explained by the fact that these are very rare. The incidence for common variable immune deficiency is 1 in 25,000, and it gets to be even rarer for patients with X-linked agammaglobulinemia and Good syndrome, which is 1 in 500,000. And we do have substantial numbers of patients with both Good and X-linked agamma. Now, with X-linked agammaglobulinemia, the diagnosis is always made after 6 months of infancy. Why? Because at that point in time, the maternal antibodies tend to disappear from the child. And this is characterized by a almost complete absence of peripheral B cells. In certain cases, some B cells do exist, but as a rule, they are absent. And we all learn in medical school is that this is because of a mutation in the BTK gene. Common variable immune deficiency is also characterized by hypogammaglobulinemia. However, the defect is not as profound usually in terms of low to absent B cells. The defect is anywhere along the maturation spectrum in antibody production, and the age at which these patients present is usually between 26 and 29. We follow, as I said, patients with Good syndrome. They have hypogammaglobulinemia and thymoma. In the past, they were considered to be a subset of patients with common variable immune deficiency, but this is no longer so. They have a complete absence of B cells. The etiology of this syndrome is unknown, and the age of presentation is between 40 and 60 years of age. As I said earlier, I've named this advanced age B-cell lymphocytopenia group based on the cohort that we saw. They also have low to absent B cells, but they have normal gamma globulin levels, yet they do also have severe and recurrent respiratory infections. What is different today, however, is that most of the patients that we see that are adults and have B-cell deficiencies have them as a result of a variety of causes. Many have lymphoma, leukemia, other hematologic disorders. Some have been transplanted. There are patients that have infections, or they've acquired these deficiencies secondary to drugs, primarily B-cell depletion. These patients can occur at any age, and they have a variability in the levels of B cells they present with, from having no B cells to having almost normal B cells. And they also have variability in presentation in terms of the hypogamma, from severe hypogamma to almost normal or normal gamma globulin levels. Now, these depleting therapies are increasing in number. The ones that are best known are the ones listed here. The first one is rituximab. This is a chimeric monoclonal antibody where 25% of the antibody is mouse. The others that are listed are human antibodies, humanized antibodies, and this is seen as an improvement in terms of minimizing side effects and maximizing efficacy. Now, these therapies are mostly for autoimmune conditions, primarily lupus and rheumatoid arthritis, but lately a lot of patients with multiple sclerosis are getting a variety of these therapies because they are so effective in treating multiple sclerosis. The deficiencies that we see in terms of B cells is transient. And why is it transient? Why? Because the targets are CD20, which does not affect pre-B cells, nor antibody production in theory, because it does not also affect plasma cells. And I'll get into that in a minute. The B cell recovery occurs at 6 to 12 months after the initial treatment. A very small proportion of patients will develop chronic hypogammaglobulinemia, and ultimately these are the ones that we get referred to us. Some, but not all, patients develop recurrent infections or are prone to developing severe infections. And the risk factors for patients to go on to develop the secondary prolonged immune deficiency are pre-treatment levels of gamma globulin, how many rounds of treatment they got, the dose that they got, and any underlying concomitant comorbidities that are either in the primary immune deficiency range or autoimmune cytopenias. When we compare these deficiencies in terms of the cause, it's obviously variable. They all have one thing in common, which is low gamma globulins. Peripheral B cells are either absent or very low in the case of common variable immune deficiency. But opportunistic infections are rare in XLA, but they are present in common variable and in good syndrome. Furthermore, we don't see many complications in XLA that are autoimmune associated, such as ITP or autoimmune hemolytic anemia, splenomegaly, and so on. We see in common variable, and to a greater degree, we see it in patients with good syndrome. When we then compare and contrast patients that received B-cell depleting therapies, we find things are somewhat different. The hypogammaglobulinemia, as I said earlier, is variable and transient. B cells can be absent, but usually transient, and there's a lower frequency of infection, both bacterial and otherwise, and it's rare to see some of the cytopenias that we see with the goods patients and common variable patients. Now, in order to understand the pathophysiology of this type of B-cell deficiency, it's important to know a bit about B-cell biology. All B cells come from the bone marrow or fetal liver and mature in the start maturation in the bone marrow, where they initially, through gene rearrangements, they acquire IgG heavy chains followed by light chains. And as they exit the bone marrow, they exit with developing B-cell receptors. Furthermore, in the periphery, they go through a maturation phase where they migrate to the spleen and they start expressing IgD. In the spleen, they also come in contact with B-cell activating factor, which facilitates lymphocyte B-cell maturation differentiation. Ultimately, these lymphocytes, mature B cells, migrate to lymph nodes where they participate in terminal center interactions, bringing them in contact with T cells. Now, what is important to note is that there is a varied expression of different surface molecules on these different cells. And this knowledge can equate to knowledge about therapy. And most of the therapies on B-cell depletion are targeting CD20, but not all. So these B cell associated deficiencies and defects can arise anywhere in development, differentiation, maturation, activation, as well as immunoglobulin production. In the germinal center, the B cell comes in contact with T follicular helper cells. This interaction is important in terms of the activation and maturation of the B cell in terms of producing antibodies, but also in terms of the T cell activation differentiation pathway as well. And what is important here is that B cell activation occurs through the CD40 ligand interaction. And once the B cell is activated, these naive B cells expand clonally, undergo somatic hypermutation, and ultimately develop to be specific through affinity maturation, undergoing IgG class switching, and differentiate into memory B cells and plasma cells. Now, in the past, we always thought of B cells as being only important in antibody production and production of plasmablasts and plasma cells. Today, we know a lot more. They are very important in antigen presentation and do interact with T cells. They produce a number of cytokines that are important not only for inflammation, but also in terms of controlling inflammation through immunosuppressive qualities. And in particular, we see an example of this in cardiovascular disease, where we think that B cells play a role in dampening the process of atherosclerosis. Furthermore, they found a niche in neurology, where they play a role in neuronal survival and differentiation. And as you can see, there are at least 4 diseases where B cell knockouts are important as therapies in at least 4 neurologic conditions. Now, what is it that we can offer here in terms of evaluating patients with these deficiencies? Well, there's a whole host of tests that we do. The important point is at the institutional level, we basically get a complete blood count, and if ordered, we can get a lymphocyte immunophenotype. A lot of the other special tests, such as memory subsets and so on, are done in labs, specifically in the ITTC lab, and most importantly, vaccine responses as a diagnostic tool for looking at humoral deficiency as well as T cell deficiency. The immunoglobulin quantification can easily be done in the central labs, but some of the T cell monitoring can only be done in a specialized lab like the IDTC lab, as we look at a variety of phenotypes and functions, and I'll get into that in a minute. So when patients are seen in our clinics, we initially may run a panel of serology looking for their past exposure to a variety of these pathogens and whether they have protective antibodies. What is really important, though, for making a diagnosis of immune deficiency, in particular humoral immune deficiency, is vaccine challenge. And in this case, these vaccines are the ones we use, tetanus toxoid, which is an excellent immunogen. It's a protein-based vaccine, and virtually 100% of individuals will respond to it with good antibody titers. Haemophilus and pneumococcal vaccines are used for 2 reasons. One is at the same time as we use them for diagnostic purposes, they can be very useful for therapy as well to prevent patients from developing these respiratory infections. What we do is we get a value at baseline, and 4 weeks later, we follow up on that value and we look for fold change. Now, in terms of pneumococcal serotypes, there are numerous of these serotypes when we use Pneumovax as an immunogen versus Prevnar. And traditionally, we use Pneumovax as the immunogen. And according to the American Academy of Allergy and Clinical Immunology guidelines, what we want to find is a post-vaccination titer of greater than 1.3 micrograms per ml. And here you can see a patient that has far less. And we also want to see a 4-fold increase in titer. So for each and every one of these serotypes, what you see here is this incredible fold change after we vaccinate a person that is perfectly immunocompetent. Although in some cases, we do not achieve a level of 1.3, in the majority of cases we do. This is unusual. Most of the time, we don't see such wonderful results, but we use this test to evaluate response to pneumococcal vaccination. When we evaluate the T cell compartment, things are a little bit different. What we're interested here is all the phases in terms of a T cell activation, proliferation, and differentiation into effector function. So what we look at initially is that naive cells, when they interact with the antigen-presenting cell, will create an activated lymphocyte, which is far larger, and one can easily identify these activated lymphocytes through the expression of many of these cell surface markers. CD25, you may remember, is also IL-2 receptor. And what happens with the expression of IL-2 receptor on the surface of the cell, it also produces interleukin-2, and in a self-serving manner, it ligates to the receptor on the surface, and it amplifies this whole process, leading to proliferation of cells. So a very important function of lymphocytes is to be able to proliferate upon recognizing an antigen. The way we do this in the lab is we stain with a dye, in this case a CFSC dye, and then we look at dilution of that dye as the daughter cells are produced. In the past, we used to use tritiated thymidine, and at the hospital, this is still used. I think this is a much more safe, efficient, and easier method to use, and hopefully one day it'll be available to everyone. In our lab, we use a mitogen stimulation, either with plant lectins such as fetal-hemagglutinin or pokeweed mitogen. We use a series of recall antigens to stimulate as well. And recently, we've been using some neoantigens, particularly SARS-CoV-2. And what we then can do is look at changes in proliferation and the ability to proliferate each and one of these antigens, both for CD4 and CD8 cells. We have the capacity also to do extensive immunophenotyping for effector and memory subsets, and in addition, look at the ability of these cells to produce intracellular cytokines. And we use a panel of cytokines that's listed here, including gamma interferon, interleukin-2, and TNF-alpha, by stimulating with these particular stimulants. In the case of the intracellular cytokines, we prefer to use PMA as a stimulant. We also use flow cytometry for both of these assays. And using these types of procedures, we can clearly evaluate what happens in human knockouts of B cells. Now, B cell depleting therapies have been around for 15 years. And what's interesting is that B cells have now been rediscovered as multifunctional major players in immunity. They're not only there just to provide antibodies. These therapies were originally developed as a method of eliminating cancerous B cells, but now there's a lot of interest in targeting CD20, 19, and BAFF because we can use them to treat autoimmune diseases. And what's interesting here is that there's a bidirectional interaction between T cells and B cells that ultimately influence not only B cell function, but also structure and function of the T cell compartment. And this is a relatively new concept that is becoming more and more interesting. So we do not have all the answers in terms of what happens with B cell depleting therapies. One of the most important questions is, what are the immune consequences of this? And how do we evaluate these therapies, particularly in the context of patients that have pre-existing autoimmune diseases or which include multiple sclerosis as a disease process. Now, rituximab is the one that's been used the longest. And as I said earlier, it's a chimeric monoclonal antibody that's directed to CD20. So because it's directed to CD20, and as you see here in this cartoon, CD20 is not expressed in pro-B cells and not expressed on plasma cells. It does not prevent B cell regeneration. These cells are still around, they can regenerate B cells. And the second is it shouldn't affect antibody production because plasma cells are there. Now, part of the problem is that because these plasma cells are there, you see primary failure of therapy over time in situations where antibodies may play a pathogenic a role in the immunopathology. In any case, treatment doesn't last forever, and after 6 to 12 months, you see a reconstitution of B cells in the body. Now, the B cells temporarily eliminate the peripheral circulating B cells. We do not know what actually happens in central compartments, such as the spleen and the lymph nodes. This type of therapy also takes advantage of the antibody-independent functions of B cells that include antigen presentation, co-stimulation, cytokine production, and coordination of T cell functions. And these functions may implicate the B cells in the autoimmune pathogenesis rather than the antibodies. These therapies do not initially affect antibody production, but can affect antibody production if they're dosed repeatedly and if the doses are much higher than they're usually used. Ultimately, we do see some reduction in gamma globulin, and IgG goes down. And in these situations, we see infections arising. And these repeated dosing or higher doses can also prolong the absence of peripheral B cells. So there seems to be a need to monitor IgG serum levels before and after each of these infusions. Now, I said earlier that between the interaction of T cells and B cells in the germinal center is important. And what's been found over time is that there's these B cell depleting therapies, although they shouldn't affect T cells in any way, they do decrease activated T cell markers, they increase TREGs, they have indirect effects on T cell function, and also decrease T cell numbers by enhancing T cell apoptosis. So a lot of the patients that we see that are treated with these therapies do have declines in lymphocytes, and this should be a red flag. Why? Because B cells only make up mostly 12% of that compartment, and the majority, 75% of the lymphocytes that we see in a differential are T cells. So when you see severe lymphopenia, this should be an indicator of not only B cell absence, but also T cell cytopenia. Now, in terms of immune monitoring, there is no specific monitoring. There are no consensus guidelines, but it's thought that we should monitor B cells initially fairly frequently, monthly or at 6 weekly intervals for the first year, and then back off in the second year. And then immunoglobulin levels should be evaluated at baseline and then in between the infusions. We don't know whether baseline immune testing should be extended beyond just looking at immunoglobulin levels, and this is something that has to be worked on. So with this information, I'd like to ask Vanessa to go into some of the case studies that we've been seeing in the clinic and give you a feeling for what this all means. Vanessa, would you like to take over?
Yes, sure. So hi, everyone. Thank you for having me. So I'll present 2 cases that illustrate the types of consultation requests we receive in the field of secondary immunodeficiency and anti-CD20 agents. So I'll start with the first case, a 56-year-old gentleman with P-ANCA vasculitis. The patient had low IgG that led to putting his rituximab therapy on hold. In fact, his last dose when we assessed him was 1 year prior to the evaluation. He still had a low IgG at the time that we saw him of less than 2.5. So when we receive consultation requests like this, we formulate some questions in our minds that help us build the framework for our investigations and for our management recommendations. So the questions that we asked ourselves were, why were his immunoglobulins low? Did he need treatment for hypogammaglobulinemia? And could he resume therapy with rituximab? So in terms of his background, he was also known for lymphoma in remission, and besides the rituximab, he was also on chronic prednisone therapy at low dose. The other pertinent part of the background history for us is the infectious history and the vaccination history as well. So this gentleman had a significant history of respiratory infections, including some pneumonias, as well as an episode of disseminated zoster. The vaccination history was important because, as we mentioned, the vaccines can be used for us as a diagnostic tool. So we like to know the baseline vaccines that the patient receives so that if we do any diagnostic testing, we have this baseline information. So moving on to the laboratory results here. So the patient had a normal white count hemoglobin and platelets. But if we look further at the differential, you can see quite a severe lymphopenia at 0.42. If we expand the lymphocytes even further into its separate compartments, you can see the CD3 or T cells, the CD19 or B cells, and the CD16 or 56 or NK cells that make up the lymphocytes. And then the CD3 can be further separated into the CD4 and CD8 T cells. So what we see when we divided this up was that the T cell absolute number was low, as well as the CD4 and CD8 cells. And this included an inverted CD4-CD8 ratio that indicates T cell dysregulation. And then of note as well is the B cells that are completely absent. Now, the immunoglobulins, as mentioned, were low, and on our repeat assessment here, the IgG was even lower, in fact, at 1.77, and you can see the normal range there is 7 to 15, so quite off of normal range. The rest of the immunoglobulins were low as well. So in order to look at the functional performance of the B cells in this patient, we look at diagnostic vaccine investigations, whereas Dr. Tsoukas explained, we take serology of certain pathogens prior to vaccination, we vaccinate the individual, and then we look at the serology at least 4 weeks post-vaccination to see the B cells' ability to form antibodies. And in this case, you can see the patient had complete absence of response to pneumococcus and diphtheria, and he had a suboptimal or borderline response to tetanus and H influenza. So we saw a functional B cell issue. Now, moving on to the functional T cell performance, we performed an in vitro lymphoproliferative T cell assay, which measures the capacity of the T cells to proliferate in response to mitogens and antigens, again, as Dr. Tsoukas explained. So this patient showed capacity to proliferate in response to mitogens or controls, as well as certain recall antigens, including Candida. And he also responded to neoantigen COVID. So he had overall a good T cell function in vitro. So in terms of our immune competence assessment, to summarize, for the B cell arm, the immunophenotype showed absent peripheral B cells, and functional testing showed absence of vaccine responses, and of course that hypogammaglobulinemia that we discussed. And on the T cell arm, we also had low absolute numbers, including that low CD4-CD8 ratio or T cell dysregulation. But we did have the capacity for proliferation of the T cells, at least in vitro. So the caveat in this patient that we weren't able to perform in vivo testing due to some logistics reasons. But the point that we wanted to make here is that even if you have low absolute numbers in both the T and the B cell arms, this doesn't necessarily equate to an absence of function. So as you saw, the B cells were absent and there was also absence of function, but the T cells were low, but we saw intact functioning, at least on our in vitro testing. So another important point we wanted to make for this case was to maintain a broad differential, even in the context of multiple signals of secondary immunodeficiency. So the patient had multiple possible causes of a secondary deficiency, and that included rituximab and prednisone therapy, chronic GI and urinary protein loss, as well as his malignancy, although this was in remission. But he also had multiple indicators that might be compatible with an inborn error of immunity or a primary deficiency. And this included his very early onset of autoimmunity at age 2, as well as the immune dysregulation and the T cell dysregulation that we discussed. So for these reasons, we expanded our differential to include a primary immunodeficiency, including a combined immune deficiency that might affect the B and the T cells, as well as genetic causes of immune dysregulation. So we pursued genetic testing, which resulted with a pathogenic homozygous mutation in DNase 1L3, which ultimately leads to decreased clearance of neutrophil extracellular traps and increased autoantibody formation. And that leads to an immune dysregulatory phenotype with typically childhood, very early onset autoimmune disease. So it's important to maintain primary disease in your differential, even in the face of increasing incidence of these secondary deficiencies that we're seeing, because they can definitely coexist. So to come back to our initial questions, so why were the patient's immunoglobulins low? Well, this was multifactorial, as we mentioned. Did he need treatment for hypogammaglobulinemia? Well, because of his absent B cell function and infections, we did end up starting subcutaneous immunoglobulin replacement therapy. Could he resume therapy with rituximab? Well, yes, if it is indicated, he could resume it, although this would require monitoring. And then because of the T cell dysregulation, we added consideration for prophylaxis. So we asked ourselves 2 further questions. Did he need antibiotic, PCP, MIA, or toxoprophylaxis, or prophylaxis for herpes zoster? So if we said for now, no, but we would consider this if there was a clinical change or an increase in his steroids. So we're following closely for this. Now, moving on to case 2, so a similar initial presentation. This is a 56-year-old female with multiple sclerosis. She was also lymphopenic, and she was also on anti-CD20 therapy, this time with ocrelizumab. And she was referred to us because of concern for opportunistic infection with her lymphopenia, so her treatment was put on hold. So the questions that followed were, why were her lymphocytes low? Did she need treatment for opportunistic infection? And could she resume therapy with her ocrelizumab safely? So again, the background history. So she was known for MS, as I mentioned, as well as some autoimmunity that was in good control. And besides the ocrelizumab, she had some other therapies previously for her MS. Unlike the previous patient, there was absolutely no history of infections or antibiotic use, so a notable difference here. And as you can see on the bottom right, she had a thorough vaccination calendar prior to starting her ocrelizumab therapy. So to go to the investigations in this patient, so again, the white count hemoglobin and platelets are normal, but again, when we look at the differential, quite a notable lymphopenia at 0.56. If we expand the lymphocyte compartment again, this time we see normal B and NK cells with the T cell compartment being a bit low, and that includes the CD4 and CD8 levels, but the ratio in this case was normal with no T cell dysregulation, unlike the first case. Now, in terms of the immunoglobulins, this patient had normal IgG and IgA, and the IgM was low, but the normal IgG was the most pertinent to us and was reassuring. Now, in this patient, instead of dynamic vaccine testing, we took a single measurement of the vaccine serologies, and she did show immunity to various pathogens that she had been vaccinated against. But in order to focus in on the main question that we had, which was the risk of opportunistic infection, we honed in particular on the T cell function. So starting with in vitro testing, again, we saw the presence of capacity to proliferate to our control mitogens, as well as neoantigen COVID, which she had been vaccinated against. But to strengthen this conclusion, this patient, we did in vivo functional T cell testing. So what we did, using the same method as a PPD test, we apply an antigen intradermally on the arm, and we look for a delayed response of raised in duration at 48 to 72 hours. However, unlike a PPD response, we actually want to see a positive test in the patient, because we want to demonstrate capacity for the T cells to respond and proliferate. So along with the PPD, we combine this antigen with other recall antigens that the body commonly recognizes, as you can see on the far right. So one of those antigens is Candida, and in this case, the patient did recognize Candida and had a normal positive response to it. So this indicated that her T cells had the capacity to proliferate in vivo as well as in vitro. So in summary, this patient had normal B cell numbers and protective antibodies in terms of the B cell arm. And on the T cell arm, she has unexplained low absolute numbers. But again, this doesn't equate to an absence of function. She has normal proliferation of her T cells on both in vitro and in vivo testing. So to answer our initial questions, why were the lymphocytes low? Well, we believe this is likely secondary to the medication therapies she's received for her MS, including the previous therapy she was on, although the investigations are still ongoing and we are pursuing genetics as well for this patient for some added reasons. Did she need treatment for prevention of opportunistic infection? Not at this time. And could she resume therapy with ocrelizumab? Again, yes, but we will be monitoring closely on therapy. So as you can see, these are two cases that presented similarly initially, both lymphopenic, both on anti-CD20 therapy, but the workup was substantially different in terms of the T and B cell function. And for that reason, our management recommendations were quite different as well. So I think these cases really illustrate the importance of doing the immune competency workup in these patients in order to form individualized treatment recommendations. So with that, I'll transfer back over to Dr. Tsoukas to conclude our presentation.
Thank you very much, Vanessa. So the take-home points here for this presentation are that B-cell depleting therapies are becoming increasingly utilized. Most patients have transient and reversible changes in immunity. The risk factors for developing an immune deficiency are premorbid immune dysfunction, low IgG, and severe lymphocytopenia. However, these low parameters, as you just heard, do not equate to poor or absent function, and it's critically important to perform functional assays both for T and B cells. One thing that does not come up often is that we only sample 2% of all lymphocytes when we do blood testing, and 2% of B cells. So there's a lack of data on what happens in the central lymphocyte compartments with these therapies. As Vanessa pointed out quite well, it's important that we not forget that we should be doing more delayed type hypersensitivity skin testing as a functional assay, which is the only in vivo test that we have for immune function. The differential should always include possible inborn errors of immunity, because there are individuals that get treated that do have an inborn error of immunity and they're not even aware of. The clinical history is critical, especially the infectious disease history, as this is an aspect that we have to take into account when evaluating immune competence. And lastly, and not least of importance, is that you can't see patients once. We see patients on a recurrent basis in the workup. The workup is very labor intensive, and we really sometimes don't come to a proper conclusion for months on end, simply because we have to complete all these tests, and some of them are dynamic, and longitudinal testing and follow-up are critical. Now, in concluding, I really think it's very important that I acknowledge the people that do a lot of the work. And one person in particular is Marie-Josée Pepin, who's been the nurse in the clinic for the last 25 years. She is really a role model for nursing. She's done an extraordinary amount of work in ensuring that our patients are seen, monitored, and treated properly. And she follows patients right across the province once we put them on therapies, and ensures that the follow-up is done appropriately. Debbie Cutler has been working with me for the last 33 years. She's been a research assistant and a coordinator for a lot of the work I've done. I think she's the one that keeps the link between the clinic and the lab such that we make sure that the patient samples arrive at the lab properly, are processed on time, and that schedules are followed. Dr. Joseph Schuster is a person that was my mentor 40 years ago when I started this work on AIDS and hemophilia. And he was an expert on immunoglobulin replacement therapy, and played an important role in the establishment of the non-HIV cohort. Reza Alizafar has been with us now for 15 years. He is an immunologist, an expert in pediatric immunodeficiency, and is responsible for the transition clinic of children that get transferred to adult care, and is an incredible resource, a wealth of knowledge in immune deficiency that keeps us on our toes. Mike Fine has recently joined us in the last 5 years, and he's has a very special interest in seeing a lot of patients referred from hematology with associated problems from lymphoproliferative diseases and malignancies. I have to point out that none of the tests that we do would be possible without Louise Gilbert, that you see standing here next to me. Louise has been with us for over 33 years. She is the lab manager, has done outstanding work, not only in making sure that the tests are done, but they're done properly. She's developed SOPs and protocols that are second to none, and make sure that of the quality of the results that we generate is accurate, and constantly strives to improve the quality assurance of the lab. To the left in this picture is Anona Kabir, who's a recent PhD student who's working on T and B cell crosstalk, and will be examining the cohorts of patients that I've described today. And I want to thank Anona for helping me with some of the cartoons and the slides I presented today. So I want to thank everyone, both in the lab and in the clinical group, for their hard work, because none of what you saw today would ever be accomplished without them. Lastly, I didn't mention was Dr. Nicole Bernard. Nicole Bernard has been a co-investigator in many studies. She's worked with me over the years, mostly in HIV, but has really done outstanding work in immunology that we know about at McGill. She's developed incredibly good assays and has trained dozens of students over the years, most of them in PhD, as PhD students. And probably the one that most people know is Galit Alter, who is probably the world's premier researcher in HIV and is a professor at Harvard. So with that, I want to thank everyone for listening to our presentation. If you have any questions, we're happy to have them.
Thank you so much, Chris and Vanessa, for this really excellent presentation. It's a wonderful way to start the year. And congratulations on all the work that you are doing. Really very impressive that this is going on at the MUHC. We have first is a comment, but I'm going to go right into the questions. That David Rosenblatt has a question about when you find a pathogenic variant, as in case 1, do you follow up with evaluation of the family? In this case, if the patient have siblings and they have altered immune function?
Okay, so the answer there is that if we find a patient that has this type of mutation, we generally would refer them to genetics rather than for us to do family counseling or testing. This is not the objective of the genetic testing we do. We use genetic testing to try and hone down on what the cause of the deficiency is rather than look at inherited factors and problems within the family.
Okay, fair enough. For the second case that Vanessa presented, if the patient remains well, that is no infections, but her lymphocyte count stays low, does she need repeat functional testing? And if so, how often?
Vanessa, you want to answer that?
Sure, absolutely. It's a good question. So in fact, as I mentioned, the patient's therapy was on hold when we assessed her. And because she's going to be restarted on her ocrelizumab, we want to follow her closely. So our plan is actually to repeat functional testing once she restarts her ocrelizumab therapy to see if the function will still be intact on therapy, because that will be very relevant to us. And then after that, there are no set guidelines in terms of reevaluation, but we'll be assessing her clinically and determining when to repeat the testing after that.
Thank you. With these low volume, high complexity tests, are you secure you can keep doing them internally with the reorganization of the labs, GRAP up to lab?
Yeah, this is a very important question, and thank you for asking it. I've been in negotiations with the lab in the past, and there were a number of obstacles. I think they're slowly being overcome. I think that certainly the proliferation assays have now been put in place, and I think that was driven by the pediatric group that required these tests to be done. The immunophenotyping is still an issue because the way the immunophenotyping is carried out, there's not a lot of flexibility. Most of the immunophenotyping and lymphocytes is directed to identifying malignancy in lymphocytes rather than trying to assess immune function. I think that this is a major problem, David. I think that we do not have plans right now to try and integrate these assays into the central labs, and I think this is critical. I would love to see this happen. This is not something that should be going on in a research lab forever.
Fair enough, very important point, as you mentioned. Mark Roger wants to know, given the shortage of IVIG, any RCTs to support IVIG use in patients with primary or secondary B-cell deficiency? That's
also an excellent point, Mark. We have to ration out the gamma globulin infusions. Most of them, as I said, are given subcutaneously, and all patients that have a primary immune deficiency do get treated if they need it. There are no randomized controlled trials that I know of right now. In terms of secondary immune deficiencies, it's very dependent on the workup. And as I've tried to point out, at least in the presentation, is we take our work quite seriously. We do not make a snap decision on putting people on gamma globulin simply because the values are low. And this has happened in many, many institutions across the country where the only guideline for replacement therapy has been the level of a single gamma globulin measurement. This should not be the case. And we take great care to make sure that we not treat people who may not really need the replacement therapy. I'm not sure if this answers your question, but it is a very important problem because this is not going to get any better in the short term. There will always be shortages of gamma globulin.
Thank you, Chris. Also very important. I'm going to come back to the comment. You got a thumbs up there from Mark. I'm going to come back to the comment from Brian. The lymphocyte proliferation we've been using in the central lab for several years has been fluorescence-based assay. Thymidine incorporation has not been done. since then. Does that change anything, or Chris, is that is that sort of the standard that we're seeing everywhere?
Well, it would be great if we could do the same kind of process where we're looking at a variety of recall antigens. To my knowledge, the assay that was set up was basically look at whether the lymphocytes proliferate, yes or no, based on the either lectins or non-specific stimuli. So what I'd like to see is that process be refined to include the recall antigens, because in pediatrics, things are very different than they are for adults. In adults, we have to look at the whole spectrum of pathogens that individuals have come in contact with over their life, whereas in pediatrics, that is not necessarily the same. In the pediatric world, it's very important that children that are very young, that are considered to have a major T-cell problem, get tested for ability to proliferate as a key indicator of T-cell dysfunction, which is a different issue than it is in adults.
Fantastic. Well, we're coming up on the hour, so we're going to stop there. I'd like to thank you very much for opening up our Grand Rounds year. This was really excellent, and it's great to see all the comments and questions. So thank you everyone for participating. We had over 120 participants today for these rounds, which is a great way to start the year. So thank you everyone for participating, and thanks to our speakers today. Good luck and congratulations on all the work that you are doing. Thank you. I see one last message coming in, and it's an excellent comment from David, and I echo that. Thank you very much to our speakers today. Have a great day, everyone. Bye-bye.